It is said that HFrEF starts at the heart and then goes elsewhere. That means it affects other systems. Whereas HFpEF starts elsewhere, that means starts in other systems and ends in the heart. So these are all the various factors, the cardiac factors, the pulmonary, the hepatic, the renal, the obesity, the musculoskeletal. And so all these factors, so metabolic stress, aging, remodeling, all these would lead to HFpEF. So the HFpEF is pathophysiologically somewhat different. Now, till now, if you look at the various trials done with perindopril, candesartan, irbesartan, then they were largely unsuccessful or failed to reduce, especially in the major endpoints like mortality. There was a somewhat of a better result with spironolactone in the TopCat trial. So probably to some extent, mineralocorticoid receptor antagonist of spironolactone had some marginal benefit, but not very significant. The observational studies suggest similar clinical outcomes. That means basically what we are trying to say is that the outcomes are not different for HFrEF and HFpEF. But now we have very good treatments for HFrEF. But as we saw in the earlier slide, we don't have very good treatments for HFpEF. That means all the previous trials have failed to sort of show significant benefit in that. If you look at the PARAMOUNT trial results, then we are not talking of mortality. But if you look at the other surrogate endpoints, so if you look at the NT-proBNP, then you can see that compared to valsartan, the ARNI produced a better reduction in patients with HFpEF. The left atrial size, which is an indicator of the diastolic dysfunction or one of the other markers of presence of HFpEF, you can see that compared to valsartan at 12 and 36 weeks, the decrease in left atrial size was much better with ARNI. If you look at the improvement in the NYHA class, again, that was better with ARNI as compared to valsartan. So basically, if you look at the soft endpoints, then HFpEF patients also get benefit of ARNI. This is the PARAGON heart failure trial, which is a randomized double-blind active comparator trial comparing the ARNI with valsartan to look at the total HFpEF and cardiovascular mortality. The key inclusion-exclusion criteria were the patients with EF of more than 45%, again, NYHA class 2 to 4, those having structural heart disease had to have elevated natriuretic peptides without any acute decompensation event. Now, the primary endpoint again was similar, that is cardiovascular mortality and HFpEF. After the run-in period, the patients were randomized to the ARNI at 200 milligram twice a day, that is the target dose, and valsartan 160 milligram twice a day. And secondary endpoints also included improvement in symptom status in terms of NYHA class, the Kansas City score, the time to first occurrence of worsening renal function, and the all-cause mortality. Now, if you look at the heart failure hospitalizations, then you clearly can see that compared to valsartan, in these patients, the ARNI did better. So the cumulative events of heart hospitalization were reduced. If you look at the cardiovascular mortality, that also is reduced, but not statistically significant. So there is, it failed to achieve a very significant reduction in mortality. But at least there was a reduction in hospitalization for heart failure, which was sort of fairly statistically significant. Now, here is one of the most important slide in terms of the crux of the issues with heart failure with preserved ejection fraction. Now, let's sort of briefly look at the gender related factor. That means there was a benefit in female gender, but not as much with male gender. But now let's concentrate on that dividing line of ejection fraction, which was 57%. So if you look at those patients who had the ejection fraction at or below 57%, then there was a benefit in primary endpoint. Whereas if they had this absolute normal or supernormal ejection fraction of more than 57%, then it sort of did not have as much benefit. So this is a very interesting thing, because one thing we have learned is that in those patients who have even mildly reduced ejection fraction, probably there will be a benefit, but we still don't know about those who have this supernormal. This is again the relation to ejection fraction in terms of quartiles, and you can see that the benefit is present when it is less than 50%. That means, for sake of definition, if you consider more than 40 or 45%, then in that mildly reduced ejection fraction, also you get benefit. In minimally reduced, you get benefit. But when you go to this normal and supernormal, then you don't find as much benefit in terms of the benefit in primary endpoint. So the EF cutoff for benefit was 57%. Now, if you look at the HFpEF and cardiovascular mortality by LVEF across spectrum, we are not talking of HFpEF now, but we are talking of all the this thing. Then, except for those with 60% or more, that means real normal, supernormal ejection fraction, all other ejection fractions, that means anything from mildly reduced to very severely reduced, that means even less than 25%, then there was a clear-cut benefit as compared to the comparator. So we know that any range of ejection fraction, except the supernormal ejection fraction, gets benefit.